Okay, just quickly a public service announcement, because a lot of us are going to be in this room for the next day or so, and not everyone knows. The bathrooms are downstairs. You can just go outside, down the stairs, and you'll find it through the door. I'm absolutely delighted to kick off this year's CDE Health and Development Conference, and I'm just so delighted that all of the speakers agreed to do this, and to agree with so much enthusiasm. I'm really personally thrilled to have you all here. I'm honored to introduce Dr. Pascaline Dupas this evening, who's going to deliver our opening plenary, taking stock of the past 20 years of applied research on health and development. Dr. Dupas is currently a professor of economics and public affairs at Princeton University. She is one of the top scholars in applied microdevelopment, using causal methods to answer policy-relevant questions, contributing extensively to our understanding of the health sector. She is particularly well known for her work that brought new insights to how best to price, target, and distribute essential health products in low-income settings. This work has been deeply influential both in academic settings and in providing policymakers with timely, relevant, actionable lessons to help reduce the burden of easily preventable diseases such as malaria. To me, this work exemplifies her general underlying approach to her work, a clear commitment to building strong partnerships within research circles, but also across the research policy divide, which is really at the heart of what I think the CDE is all about. She earned her PhD in 2006 from the Paris School of Economics and has previously worked at Dartmouth, UCLA, and Stanford University. She is a BRED, NBR, and JPEL affiliate. At BRED, she is currently serving as co-president. At JPEL, she has been serving for a long time as the lead of the health sector and is currently transitioning to be the co-scientific director of JPEL Africa, which I'm particularly happy about. She's a prolific academic, publishing in the most prestigious journals, including the American Economic Review, Quarterly Journal of Economics. I could go on and on and on. I think it is clear that her work is very influential. But I think what we'd all prefer is to be able to hear and learn from you. So I am going to pass over, and thank you so much for coming. Thank you.
All right, thank you so much for having me. It's a great pleasure to be here and a great honor to share with you some kind of taking stock of 20 years of research. I finished my PhD in 2006, so it's not quite 20 years ago, but I started doing research as a PhD student, like many of you, and so it feels like it's reflecting on what I've been trying to do with many of you in this room that have been also interested in the same issues, and many more outside that all share a common goal of trying to make the lives of the very poor slightly better if we can. So let me, okay, it was working. We've been having some slight technical challenges. Okay, I'm gonna have to rely on you guys to move the slide. Okay, it doesn't move at all. Okay, it's fine. I can do it without slides, so. It was before, but okay, all right. Oh, yeah, okay, that's gonna be tricky. All right. So, as you know, it was already mentioned by Q earlier that we care about the health not just because it's a productive asset or a form of UN capital and something that we believe matters for how rich you can become, but also because living life healthy and having healthy children is obviously a key component of quality of life and something that is an end in and of itself. Good health is also a source of externalities in the sense that if you're in better health, you're less likely to make people around you in poor health. I guess after COVID, it's an evidence. We all know that. Before COVID, it was not that obvious to everyone. And finally, it requires expertise. When we feel sick, sometimes it's pretty obvious what we have, it's just like a common cold, and sometimes it's pretty tricky, and we need to rely on experts to tell us whether we need, a stent or something like that. And so, for all three reasons, it's going to be very important to not leave to not leave health just to the private market, and we're going to need to have public intervention. So we need active government participation, and I'm going to argue we also need, to a great extent, international cooperation. Most visibly this has been thought about in the context of COVID, and we didn't do very well on that front. So hopefully we can do better going forward. So let me just start with some, just basic facts about health. This is, a graph that our world in data had in the past, that they're not anymore on their website, but you can download their data set and reproduce it. It shows what we call the Preston curve. The Preston curve is listing the life expectancy at first against GDP per capita. And what you can see from this graph, what's really remarkable is that for the same amount of money per person, you get way more health today than you did back in 1900 or back in 1900. So the same amount of money buys you way more health today in the form of life expectancy at birth. And that's because we've been essentially making tons of progress on many fronts, and this is the event of drugs and many other countries. Okay, but so with the same amount of money, you get way more. Another piece of good news, and that's obviously related to what we just saw, but not only for the very last part. Top part of the previous graph, it's the fact that in the last 30 years, there's been massive gains in terms of child survival. So this is showing you the likelihood that a child dies before reaching the age of 5, and it has really declined. And we still have a good chunk of children, unfortunately, dying before the age of 5 in sub-Saharan Africa, but compared to what it was way back when, it's much decreased. So from 18% to below 8%, and for Southern Asia, it's gone down from over 12% to below 4%. Now that's also a massive gain. Now, not all metrics have seen improvement. This is showing the maternal mortality ratio. This is the likelihood that you pass away if you give in the process of giving birth. Something that many women do in their lives is give birth at least once, and this is something where it's still very, very risky for women in many contexts. I showed you an example of a set of examples here: Haiti, Congo, Senegal, Malawi, Uganda, Peru, Sri Lanka. But if we put India on there, it wouldn't look too good either. So it's still an area where progress has been lacking. So if we look at the relationship between the disease burden to communicable diseases and GDP per capita, we still have a very strong negative relationship. So the countries that are much poorer have a much higher disease burden for communicable diseases, and that's something that it's gone down somewhat, but it's still very, very much there. So the likelihood that you do well in terms of your health in life is still extremely linked to where you were born. So another bit of ignorance, most people would choose to be born in a country where they can face a much better health level. If we look at non-communicable diseases, we find a much less pronounced downward sloping relationship, but people tend to think that the non-communicable disease burden is disproportionately in rich countries. It's not actually the case. So it's much more. It's still actually somewhat downward sloping, maybe to some extent a little bit of an inverse U, but you have a large and growing non-communicable disease burden in low-income countries, in part because of what we've seen before, which is people also live somewhat longer, and so then they hit this type of other diseases. Next slide, please. So this is another way to look at it, which is looking at the fact that if you could hold the age distribution constant, you would see a decrease in the DALY rate. So DALY is like disability adjusted life year. It's a metric that health economists use to, or public health folks use to think about the quantity of damage to your life that poor health does. Okay, so the more DALYs, the worse you are. So if you have a disease that's somewhat debilitating, it's going to reduce your quality of life by a certain amount. And how exactly that's done, you don't want to look too closely at whether they say that losing one eye is worth more or less than like losing one limb. Like I don't know who does these assumptions. It's very hand-wavy to some extent, but the point is that to the extent that you keep that constant over time, you can look at the trends, and if the distribution, if the life expectancy, if you will, had not, if the population had not been aging, you would have massive gains in the form of this age standardized daily rate going down. But because population has been aging in total, the daily count in the world has been flat. Okay, but so it's a combination of two things: people doing better in many contexts, but also reaching ages where you have more disability. Okay, so now it's a mix of good news and bad news, but there are still some deep challenges that remain that I want to highlight. So one is malnutrition. I don't know if you can click on the map thing. I guess not asking too much. Okay. It's okay, we can skip the map. You can imagine, I'm sure if you've seen a map of GDP per capita, the map of malnutrition in the world, it's going to look pretty much the same. But especially after COVID, and we don't have data everywhere, but after COVID, it was estimated that the share of children who were underweight was really large, and close to 1 billion people may be undernourished worldwide. Obviously, these are all guesstimates, okay, but a very large number of kids. And malnutrition is linked to many other challenges in life going forward. You're going to have to go back by clicking right there. Sorry, let me help you because this one is tricky. Okay. All right, okay, and then down. You can keep going on. That's when I regret having put some pause in my LaTeX. All right, so the main thing that I want to focus on today is the fact that the environment that people face is still, very poor, in a sense that the disease burden remain very high. We've just seen that, but in part there is still malaria, for example. It's not been eradicated. There is now a vaccine that people are hoping is going to make some dents, but it's not by any means of perfect. It has partial coverage. It's not yet been rolled out much, so we essentially still in a world without an effective malaria vaccine. Many people don't have access to clean water and sanitation. There is lead contamination in many contexts. My former colleague at Stanford, Steve Luby, has found lead in many parts of people's environment. In Bangladesh, also in India, probably many other places where we've not even tested for it. There is no fluor in people's running water. If they do have running water, there is no iodine in their salt. So all of these things that we take for granted that we have, we don't even know it's there. Like, do you even know that there's iodine in the salt or that there is fluor in your water? Maybe not. You just take whatever the government happily provides and or regulates and are healthy for it. But in many other contexts, people don't have access to that. And I'm going to argue that some environmental challenges are worsening. So the air quality that people face is getting worse. Climate change is going to increase the odds of highly unhealthy extreme weather events. And we all know this is not going to be an issue here. And you guys are going to be better off here from climate change. It's not going to be an issue in Minnesota. It's not going to be an issue in Canada. It's going to be disproportionately in the country that are already very hot. People have estimated that the extra deaths from climate change are going to be primarily in low-income contexts. Okay? And then the locus of ill health is also shifting from rural children that used to have very high infant mortality to urban adults. And I found some estimate that showed that the life expectancy in Mumbai, in the slums of Mumbai, is only 44, and that's where 50% of the Mumbai population lived. And the adult mortality rate nowadays in cities in sub-Saharan Africa is higher than in rural areas. So people coming to urban areas that don't, without sanitation, without access to amenities, living in pretty tricky shanty towns, as they are called, end up having very high mortality rates. And on top of that, the health poor are getting harder to reach. Okay, so you can have safety concerns. So nowadays, more than half of the extreme poor live in conflict areas, which means that reaching them through traditional programs can be quite difficult because they may if they are in refugee camps and you have access to refugee camps, maybe you can do something, but in many contexts it's not possible to do anything, or if you do, you may die, as has happened very recently in Gaza. Forced migration is also a consequence of conflict. Nearly 80 million people worldwide are uprooted. Again, it's pretty tricky to access healthcare when you are on the move. And then another issue is that many of the very poor in terms of health are actually in countries that are not so poor, okay? So this is a point that Page and Pandey made in 2019, where they say many of the poor and stunted live in middle-income countries. So here maybe it's a choice by their government not to do anything about that. The same way even within the US, there's a massively unequal access to healthcare and massive inequalities in health levels, and most famously, Anne Case and Angus Deaton have made that point, showing a massive decrease in life expectancy for some group of the population within the US. Part of the, so some of the inequality can be within country across households. Some of it can even be within households. So you can have poor people within non-poor households, okay? So most commonly, this will be women or children who are not the firstborn son. Okay? So that's been shown, in various contexts. For example, Brown, Ravalion, and Van de Valle in 2017 have a paper showing that 75% of underweight women and undernourished children in sub-Saharan Africa are not found in the poorest 20% of households. And around half are not found in the poorest 40% of households. Okay, so then it's like the households make choices not to invest as much in the health of every member of the household, and it's much harder to do something about it. So with Radhika within the room, and we're going to present some work of our own tomorrow, we have a paper where we look at access to healthcare in India, in particular in the state of Rajasthan, but we've also done some work in Andhra Pradesh and in Tamil Nadu where we found similar results. This on the next slide, we find that women don't get access to care as much as men, even when you provide, you put in place a system of public health insurance where it's supposed to be free care for the poor. So what this graph shows from the paper with Radhika is in blue, it shows you the share of patients for a given age group that are women, based on claims data that we got from essentially the government sharing with us claims filed by hospitals to the insurer, okay? So when a hospital sees a patient, they have to get reimbursed for the care by the government program, they have to send claims, okay? So this shows you, for example, that among patients treated for chronic kidney disease, only about 20% of the age group 0 to 14 is female. Okay? It goes a little bit to, up, it's 30% in the 15 to 49, but it never goes anywhere close to 50%. Now, India is an issue of missing women, as you may know, but it's not anywhere close to that. So it's about 48% of the population of Rajasthan is female. And, if the distribution of chronic kidney condition is equally distributed between men and women, you would expect about 48% of patients to be female. Now, is it the right assumption that it's as likely for a woman and a man to get a kidney problem? Maybe not. We can use this global disease burden data set to give us an idea of what we should expect. Okay, so again, this is, a lot of assumptions go into this, but people spend a lot of time trying to get a sense for what is the prevalence and the incidence of various diseases by gender and age group. So when we use that data and plot it, these are the red crosses, it tells us based on these data sets for India, what is the expected share of patients that should be women, given what we know best about the prevalence. And so this is what we would expect. So indeed, it would not be quite 40% of 0 to 14 patients that would be female, not quite 50%, it would be 40%, okay? So that's the benchmark, if you will. And we see only 20%. So the gap that you see between the blue and the red is evidence of missing female patients, okay? And we see that across the various specialties for which we were able to match between the various technical names given in the claims data from the specific program in Rajasthan we are working with and the global disease burden. But you see, gastrology, ophthalmology, oncology, psychiatry, neurology, cardiology, nephrology. These are the domains where we could do this. The only one where you see, no evidence of a gap is for ophthalmology for this age group. You still see a gap for the kids. Okay. So that's just to highlight the fact that you can have inequality within the household. Yeah. Now, another aspect that where I think we have actually very little information, even though it's very intuitive to all of us, is the idea that on top of the hurt and the suffering that goes on when people are sick and don't have access to care, is the fact that they may be much less productive. And this is something that's very intuitive. When we get sick, we don't show up at work, we can't get out of bed, we don't get much done, and yet there's not that much of a quantification, and maybe David will correct me tomorrow if he has done it and he knows exactly. But at least from a micro perspective, I'm not aware of any good micro studies that has been able to just quantify how much is lost to disease. So there are a lot of survey evidence. Many of us do surveys on a regular basis with households, and we ask them, how many days of work did you lose to illness? And they report quite high numbers. Here's an example of a study in Zimbabwe in 2019 that estimated that workers at the banana plantation lost 9 days of work to malaria per year. That's just malaria. That's just one disease. Okay, there are many others. In Côte d'Ivoire, a 2022 survey that we did with Marcel Favchamp in the greater Abidjan region, which is kind of like semi-urban, we found that 38% of the respondents reported a serious illness in the past 12 months. And conditional having a serious illness, they lost 34 days of work on average, the median being 14, okay? And 7% lost their job as a result. So pretty large numbers. So I think it'd be great to have more evidence of just the sheer quantity of hours worked, hours of work lost to illnesses, because I think we don't talk that much about that when we think about the reasons why you don't have that much foreign direct investment coming into low-income countries. You don't have that much, tourism revenue. When I told my colleagues a few summers ago I was going to go on vacation to Senegal with my daughter, they were like, "What? You mean you're not going there for work, just for vacation?" Yeah, why not? It's not top of mind. People don't think of certain destination as being an obvious destination to go on vacation just because they think immediately when they hear the name, or they think about the disease burden, they think about, and not so much, whereas Senegal is a fantastic place to go on vacation with very rich history. I highly recommend it. There's also a very interesting paper recently by Bassi et al. Looking at firms in Uganda, where they show that many firms that have 5, 6, 7, 8 employees, they don't actually use their employees they don't specialize at all within the firm. Each employee is kind of its own mini firm. So let's say you have a firm that does, beds, out of bed or out of wood, or that does windows or doors, and then every single worker does a bed from A to Z. Every single worker does a window from A to Z. It's not like I specialize in doing the feet of the bed and you specialize in doing something else. And they argue in their paper that it's because there are these unbundling costs. It's they are macroeconomists, so they have this model and they just say, we have unbundling costs, which means that it's costly to separate out the tasks into different things. And I think one potential source of this unbundling cost is the fact that absenteeism due to illness wreaks havoc when you have a production chain. Because if the guy who knows how to do the feet, on the bed is not there for a week because he has malaria, then you can't finish the bed and you can't deliver to the client. Okay, so that could be one opportunity. So I think how to think about the disease burden and its implications for firm organization is something that we've not really done enough, that I would love to see more work on going forward. Okay. So, this was kind of a long prelude to what I want to talk about, but I think what we've done over the past 20 years in the macro side is learn a bunch on how to improve health outcomes. We've done some work on subsidies, on behavioral interventions, trying to think about ways to better incentivize providers, incentivize people to take up stuff, thinking about how to improve quality of care. But I'm not sure this can take us very far. And I'm saying this having spent the last 20 years of my life working on these things. And so I'm going to say, well, we've kind of been just looking under the lamppost, but it's not going to get us where we want to be. Because if we want to really get universal access to health, we need universal access to a healthy environment. And that's not going to happen through small interventions focused on individuals. Instead, we need to put malaria eradication back on the table. We need to prepare, and by that I mean sanitize, if you will, cities for a wave of urbanization. Before people show up and build, expand cities and end up in slums, we could build public housing for people to move into. I was in Abidjan, in fact, a few years ago when they were about to host some soccer cup, I think it was the Africa Cup or something like that. And just in a few months, they built up entire villages, for the athletes. And I was like, well, who is going to live in there after the athletes are gone and the Africa Cup is over? These are actually pretty nice, dwellings. And why not do that, at scale in many other places? And so some countries have done some of that. Like Ethiopia has built a lot of public housing in the outskirts of the city. Now these are actually pretty fancy things, and they allocate them through lottery, and you have to be quite middle class to be able to access them because you still have to pay a huge down payment. But you could do this, at even bigger scale and more modest type of housing that could be affordable to many more people. But if you don't do that, like if you take Dhaka today in Bangladesh, and you're like, well, how do we make Dhaka more, healthy in terms of access to amenities? It's really hard. You have 18 million people. Unless we just take them all to Wyoming for a couple of years while we, build infrastructure. I think that's a great idea, but no one ever believes that it's possible. So, but you can't. People are there. You don't even have the space to build infrastructure. So we have to anticipate, and before people show up, get cities ready for them. Reducing air pollution, obviously. Climate change, both mitigation and adaptation are going to be absolutely key. And then to deal with issues within the household or within the society that discriminate against some members, we need to eradicate discrimination, which is also something that need to be thought of from a not macro perspective, but not at the individual level necessarily. So let me now tell you where we've made some progress, because we have made some progress before I go back to these broader issues. So if you want to write down a very simple empirical framework or conceptual framework for how we think about access to health as a macro development economist, we're going to think about the main determinants of access to care as being the cost. Okay, so you have distance, which is a cost. If it's too far to go to the hospital, you can't go to the hospital. Out-of-pocket charges, which is how much you have to pay to get the care. And then waiting time, it's another form of cost. If you have to wait 6 hours to be seen, that's 6 hours during which you can't take care of your children, you can't farm your plot, you can't do your job, you can't do any other thing. So that's another cost. Then the main determinants of impact to having greater access to care are going to be the quality of care. And so for that, whether your providers have been trained, what the effort level of the providers, and what equipment they have to their jobs. Even if they are very well trained and they work very hard, if they don't have, they don't have access to equipment, there's something that they won't be able to do. And then there may be some demand side issues. I'm going to argue this is kind of like overall not as important, okay? But the important demand-side issues, if there are any, I'm going to argue are going to be trust, okay? And that's because of the history very dark history of how, in many contexts, people have been fooled or taken advantage of or misled. Marcella Aslan, in the context of the US, shows massive mistrust of the health systems among African Americans due to the history of the Tuskegee experiment, which was an abomination. In case you don't know about it, you should read about it. I don't have time to explain, but it was essentially voluntarily withdrawing treatment from African American men just for the sake of learning how bad those things get when you don't treat people. Okay. and Sarah Lowe's and Eduardo Montero have a paper looking at the legacy of the French colonial powers in, the former AOF, the French Empire in Africa, where the French were doing forced vaccination against the sleeping sickness, and doing it in a way that was, removing any agency from the local population, and in some contexts doing it without really knowing, what the right dosage was. In fact, there's a beautiful novel about this by a Cameroonese writer called Mutlon, called I don't know in English. I read it in French, but it's about the fact that at some point there was a rogue French doctor who decided to give three times the dose to folks just to see whether it was going to make a difference, and then that led to blindness. Okay, and so this book is about the history of how people would become blind, and then some of the other doctors were like, yeah, there is something wrong here, but no one had the guts to report it to the higher ups. So in such a context, where for years and years and years you have colonial powers that impose things that are clearly bad for the local population, in the name of science, in the name of modern medicine, in the name of you name it, it can take a long time for trust to be rebuilt. Okay. Discrimination within the household is, I've just mentioned it before. I don't think it's second order. Bandwidth, what I mean bandwidth is just the fact that when you have so many things that you have to do, it's kind of like hard to remember. So there's this very nice paper, if you can click on the Malawi thing, by Derksen et al. Recently, where they look at something very simple. If your hospital actually give you an appointment, okay, it really helps people be more likely to be able to avail themselves of something like HIV testing. So this is a population that needs to come back for HIV testing regularly in Malawi. And they're randomized whether or not people were in a control group, which was the status quo where the health workers don't tell you, you don't give you an appointment, versus one where you get an appointment, and the fact that they find that it increases the likelihood that you show up for an appointment by 16 percentage points over a mean of 10%. So something as simple as getting an appointment, which we take for granted, like I would never have known when to get my kids vaccinated for their second, third, fourth shot of whatever they're supposed to get if I was not getting a reminder in my email, hey, it's time to bring your kid. We've automatically booked them for an appointment on that day. It would be very hard for me to stay on top of that. So that's a pretty obvious thing that you want to do to help people deal with that. You need to go back, do more, now, where I think it's really second order, but yet there's a lot of work on that, is more things like present bias, free riding. I think it's like looking at a little bit really under the lamppost when we focus on that. So let me give you an example from actually somebody that's very dear to me. She's my former student, Rebecca Dizenross, with Ariel Zucker. She's the superb economist. But this is an example of an intervention that she evaluated, where they look at the effect of giving people incentives to walk more, do more steps. Okay, obviously it's important. We all want to do as many steps as we can, and we have our watch. I mean, I guess I don't have the fancy watch, but my phone tells me how many steps I do. But especially if you are pre-diabetic, it's pretty important to do more steps. So this is an extremely well-crafted randomized experiment to understand the impact of essentially targeting the incentives that you give people. So like, I'm gonna pay you some money if you do that many steps, and how I set up that incentive, and how much money you get for each extra step is gonna be a function of your time preferences, something extremely theory-driven, which is great, but in the end, my point I want to make is that, yes, you see a difference in these bars, okay? So if you give people a choice of how you want to structure their incentives, they get to do more steps, like 8,134 versus 7,187. But I don't know, like an extra 1,000 steps a day on average, maybe it's a big deal. I don't know, maybe it's not that much of a big deal. And so, we can go into a lot of, details like that and try to figure out exactly how to, optimize the amount of money we give. But to me, it's going to be still small potatoes compared to the gain that we can make if we focus on the bigger elephants in the room, which is the environment that people are in. Yeah. So I think there's a bunch of low-hanging fruits, and we've kind of like harvested a bunch of them. I apologize, there is a typo. There is something that showed up twice. Unfortunately, it's linked to my name. I was not trying to maximize the number of citations. I just did a copy and paste a little bit too quickly. But so free and easily accessible vaccines, I think, is an obvious thing that we know works, is important. That's how you get kids vaccinated. Free antimalarial bed nets given as part of the prenatal care package is something that I've worked on with UCICACO and that now has been adopted by many governments, and we know that's important. My new battle is to make water treatment solution part of the maternal and child health package. We've shown in various studies that it really helps, and it's extremely cheap. So now the question is, how do you get government to integrate that in the package? We are working on that in Nigeria, Kenya, Rwanda, and hopefully more countries soon. All of this is highly cost-effective, very cheap per capita. It's a no-brainer. You want to do that. Okay. Free and easily accessible primary care, especially maternal and child health, also makes a big difference. There's a very nice paper in Thailand by Gruber et al. That looks at what happens when the government of Thailand rolled something like that. They find a big decline in mortality. And then school-based delivery of things that you can do through schools, like deworming, most famously. Owen here has a paper looking at the long-term effects of deworming. Some kids on even their siblings, and so it's a really great. Not only you have direct effects, but also indirect effects of on other generations, which is really a great buy. Nutrients, you can give kids nutrients while they're in school. I've worked on HIV education in school. All of these are like cost effective just because the delivery is pretty straightforward. So a lot of this were the focus on the MDGs, the Millennium Development Goals, and there was great success, substantial improvements. What's next? So the not so low-hanging fruits are, improving the quality of the health service provision. And so number one here, I would say, is eradicating medical deserts. And Susie and Eduardo Keke have some great work on that, showing that, if you ban, informal, traditional birth attendants or informal health workers from doing their work, you may not actually get much in exchange, even if people start going to the public health system as a consequence if you don't have enough qualified staff there. So it's really the quality of the personnel that's going to really matter, okay? And Eduardo Keke has a great paper that's just in the AER 2023 showing that in Nigeria, when the government randomly assigned medical doctors to some villages instead of mere community health workers, you see a big decrease in child mortality. Okay, and I don't think I have time to click on the link, but it's a really drastic drop. And so this is because death in the next 7 days after birth really goes down when you have access to a trained medical doctor who's going to know how to deal with this, with the challenges, the more complication that can come. Okay, so when you can't, but unfortunately, there's a dearth of trained medical doctors in many contexts. And so one policy, if I were super rich, I would just build medical schools, everywhere around the world, and just or provide scholarship for many folks to go to medical school, because we just need more doctors, trained doctors. If you don't have that, the second best can be community health workers. But they're really a second best because there's a lot of stuff that they cannot do. What they can do is increase access to this basic stuff we mentioned before, but they are not going to be able to deal with more complications. And then the third best may be to train informal providers. And so there's some work on that by Jishnu Das and co-authors in India, where they took people in India, 50% of the care is provided by informal providers who have no medical training whatsoever, absolutely none. Many of them have not even high school. And if you can train them and increase the quality of care they provide a little bit, okay? Still not great, but you can improve the quality. Since they are the ones that people do go to, you may as well make them better, okay? But that's really a third best. A lot of work has been done trying to think about how to better manage existing human resources, short of expanding how many trained workers we have. And it's not that easy. So top-down accountability can be quite difficult. There's a number of failures trying to say, we're going to give you more money if you do a better job, or we're going to sack you if you don't do a good job. It's very hard to do because whenever you put an incentive like that in place for health workers, you need to monitor their performance, and then you need to monitor the monitor, and then you need to monitor the monitor of the monitor, and then it goes on and on and on. So it's actually pretty hard to do. And then the alternative to top-down is bottom-up, where you say, okay, well, the end users are the ones who really have everything at stake here, and so you can harness their desire to have better access to care by putting them in charge of holding their providers accountable. But that's actually pretty hard. Because it's very hard to know if your doctor is not doing what they are supposed to do or your nurse is not doing what she's supposed to do. So in an early study by Bjorkman and Svensson, they found that it worked pretty well in Uganda in a context where you had a very low baseline rate of healthcare quality. You can get things better when you start from a very low base. Telling people this is what you should be getting, ask for it. It can help a little bit. But as soon as you've gone a little bit up from that, it's very hard to make any more progress by relying on the very people to get access to what they, to improve the quality of the care they receive. And then there's also some work on financial incentives for providers that have found that, well, if I'm telling you I'm going to pay you more if you do better, it can work, like, incentives work in some sense, but it only works if you know how to do better, okay? And so if you tell, the same way it's been found, if you tell the students, I'm going to give you money if you get an A, well, if they don't know the production function of an A, there's nothing that they can do. If you tell them, I'm going to give you money, if you do your readings, if you do this, you give them the inputs, you pay them based on the inputs, then they can get the A, okay? So it's the same with many of the health professionals. If they don't have the training to achieve an outcome, they won't be able to achieve the outcome, even if you financially incentivize them. The not so low-hanging fruits part 2 is availability of drugs and vaccines. There's a huge problem of counterfeits. We've not yet figured out how to deal with that. And then there are a huge problem of neglected diseases. These are diseases for which there is actually not enough innovation because the very people who need the innovation are not able to afford to pay for it, and so pharmaceutical companies have no incentives to do any research. So for that, we have a solution. It's called advanced market commitments. Michael Kramer has been the person who's going to push this. And there is some evidence that it can actually work, but for some reason it's not really been taken up enough. And then the next big thing is health insurance. And so on that, this is really an area where much more research is needed, because what we know is that it's not that easy to put in place health insurance programs. We were just talking about this at dinner with Fabrice. Some countries have kind of put in place large health insurance programs and told people, hey, come, sign up. And then they find that people don't actually sign up that much and are not willing to pay the premium. And like, okay, why is that? Well, because you have to trust that you're actually going to get the care in exchange, and that may not happen if the hospitals are going to turn away patients or they're not going to be equipped to provide good care. So a lot of challenges come into the design of health insurance. Tomorrow, Rebecca will present some wonderful work on, unfortunately, finding pretty damning evidence that hospitals engage in fraud in a health insurance scheme in Rajasthan, which means that it becomes very expensive for the governments to do that. We also have some work with Radhika finding non-compliance with program rules in terms of charging patients even when it should be free. But on the whole, this is an area where it seems to be obvious that access to health insurance is a key component of someone's quality of life. It helps you not become impoverished from having crazy care expenses when you're very sick, and it helps you get additional preventative care when you need, but most people around the world don't yet have that. Okay, so now the irony, if you will, is that the solution identified in the past 20 years where we actually have made success is really what you can call the inverted model of healthcare, where we have private provision of public goods. It's the very individuals who have to do all the work, okay? They have to pay the effort cost of using a bed net, which means like every night you have to like untie it and putting around your bed instead of having no malaria in their environment. So the public good is the government or the spraying DDT and eradicating malaria. But instead, it's the individuals having to put the effort every day to have a bed net over their head and their kids' head. And they also have to put chlorine in their water. Okay. They have to put chlorine in their water every time instead of just getting water chlorinated at the source on the pipe. They have to use a pit toilet and drain it and desludge it every once in a while instead of having a sewerage system. They need to have air purifiers running instead of just having clean air. They need to invest in clean cook stoves where instead of just having access to an electric one. That's much easier to use. So this is really the fact that in the end is every single individual ends up putting in the work, and that's what I'm going to call private provision of public goods. Okay. And then the inverted thing is that then you have public provision of some private goods in the sense that some of the investments in primary care, at some level you could say, oh, this, a lot of those returns are like just private returns. People could invest that in that on their own, and instead you would want the government to invest in the bigger ticket items that individually people can't afford. Next one. So, that's why my not so positive opinion of what we've done over the past 20 years, and again, this is a statement of how me reflecting on my own the limitations of my own work to some great extent, is that we can't go that far in terms of improving the lives and the health of people who live in contexts where they have really an unhealthy environment. Okay, next one. Now, what's really tricky to make progress on these things is that a lot of these are global goods. So malaria eradication, TB eradication. In the past, after World War II, there was a big effort to try to eradicate malaria from around the world. It was, an international effort. For a single country to eradicate malaria, it's pretty tricky because the mosquitoes can just cross borders. So you need to do a big push. Obviously, climate change mitigation is a global good, and to a great extent, I would argue that the most efficient and rapid way to help adapt to climate change is by opening borders. Immigration policies, if they incorporated environmental justice concerns, would immediately acknowledge the fact that we need to have way more immigrants coming to countries that are not going to be suffering as much from climate change. So asylum for climate refugees, that's obviously something that I'm going to argue is a global good. And that's really tricky because we don't have institutions that, we have institutions that pretend to be global institutions like the UN, but we all know they don't really do anything. So it's really tricky to do any progress there. Sometimes some of these are like national level policies, like preparing or sanitizing cities for the wave of urbanization I was mentioning before, or eradicating discrimination. This can be things that can be done at the national level. But whether or not it's a global level or the national level, political will is obviously a big issue, and we are pretty much stuck. Okay. On top of that, at the national level, sometimes you have issues of state capacity, and right now we have this added challenge of crippling debt burden. So many countries don't even have the resources to do any of that stuff. So, next one. Okay. So, what can we do, and who should pay if we wanted to put eradication back on the table? A few years ago, I had a lunch with the president of the World Bank at the time. What was his name? Jim Kim. Thank you. He was not, I tried to erase his name from my memory because when I said, hey, how about malaria eradication? He was like, you academics, you're useless. Like, there is no way. Like, move on. Like, no. And I'm like, dude, you're the president of the World Bank. Like, can we at least discuss it? And he was like, no. It was a non-starter for him. Like, no. Like, and I was shocked. I was stunned. Like, it is a big deal. It still kills a lot of folks. It makes people lose many days of work. It is a big deal. Why can't we just talk about it? No, it was like it's moved on. So I lost faith in that. But I guess I have to conclude. But you can scroll to the end. But I want to, like PEPFAR. PEPFAR was in place. I was not a big fan of Bush, and so I thought, I kept saying bad things about PEPFAR, just also because it was like abstinence only and no condoms and stuff like that. But the truth of the matter is that PEPFAR has been an amazing program. It has saved so many lives because it had made antiretroviral therapy available to millions of people, and it's been called by Justin Sanderford at the CGD the most significant global response to a single disease in history. Okay, and the most successful U.S. foreign aid program since the Marshall Plan. Okay? And so I would like to argue that it's time for another Marshall Plan, but this time it should be paid by the former colonial powers, France and the UK, who've never done anything like that, and just kind of like, okay, let's just do it. Let's just do it. Let's just not give up. Bill Gates is not as optimistic as I am. I guess he thinks it can be done piecemeal. I don't think it can be done piecemeal. I think we should not give up on the international effort. I think I may be done. Is there one more? Yeah, okay, this is the conclusion. So, we've had great progress in health, and, you can live much better now with less money than before. But we are still in a world where it's extremely unequal how much health you're going to have. We know exactly where it's going to be worse. We are not under the veil of ignorance, which is the reason why there is not enough willingness to change things, because the folks who have the resources and the decision power are not affected by a lot of these problems. But we need to stop. We can continue doing these small-scale improvements, because in the meantime, that's what we can do. But I would like to argue that we want to make sure that these big elephants in the room are not left behind. We need global coordination. We need the Ministry of Health also to work with urban planning when it comes to sanitizing cities. And I'm hoping that the macroeconomists in the room will tell us over the next 24 hours how they are going to help make the powers that be, help move the needle on this. Thank you very much.
Thank you so much, Pascaline, especially for all the adaptability with our technological issues tonight. I'm really appreciative of that. I know we're over time, but it's because on our side, not because of you. And I do want to give the audience just opportunity to ask questions. We won't go too long, but maybe if we can take 3 questions and I'll have you respond and then we can wrap up. But I encourage all of you who will be attending tomorrow to find Pascaline and ask her your questions. But if we could take a couple of questions and then I'll have you respond to the set of questions. Just quickly. Okay, I will go there, but I do want to encourage one of the CDE fellows to at least ask a question, but I promise I'll come back to you. Yeah, okay, go for it. I'm going to give you the mic. There you go. Thank you.
Thank you for this talk. I found this very interesting. I have one question, Pascaline. Where do you see the role for funding of medical research, say, on vaccines? Because if you talk about malaria, there's a lot of research also on vaccines against malaria. This could be another angle, essentially, that could attack this major problem, that we are not getting control over the environment, rather we get control over the disease the other way around.
Yeah, so there is some research on malaria vaccine, but it's not done by pharmaceutical companies. It's done essentially, it's either like the Gates Foundation has been funding a lot of it, or like the NIH, or it's because there is no financial incentives for a private firm to do that. Just because the folks who would need the vaccine wouldn't be able to pay very much for it. So there's not enough, if you will, and it didn't start early enough. So it's really when Bill Gates was like, okay, this is my number 1 priority, but he's been pushing for that for many years now, and the progress has been very slow. Why? Because the malaria parasite, unfortunately, is extremely savvy and clever, and so it's a really complicated problem to come up with a solution. But there are some other diseases where vaccines could potentially be more like easier to find. And when you see how amazingly fast they came up with the COVID vaccine, you're like, okay, well, when a lot of money is on the table, stuff happens. But it's not happening if there's no money on the table, and so that's the prime of neglected diseases. But that's potentially one mechanism for coordination, where you would think it shouldn't be that hard, except that there's always some more pressing problem at home, so people end up not putting the money behind it. And for HIV, for example, the reason why there was a lot of research that was put in by governments in France, in the US, and they still disagree as to who came up with understood the disease first. Wasn't because the disease reached rich countries and the epidemic started spreading, and that's why they put a lot of resources behind it. But for diseases that are really specific in the tropics, there's much less will.
Roxana, here we go. Taking one for the team.
Thank you for the presentation. What do you think about the role of belief, culture, tradition as an impediment of the health improvement in developing countries, especially in Africa?
So I think everybody has the same preferences, which means that they'd rather not have pain and not see their children die. So, that everybody, irrespective of where they're from and their culture, have this, those same views. I think the beliefs come into play when it's about trust. I mentioned trust in the system. I think like information about what's going to help you or help your children may be difficult to get. It may be very heterogeneous across contexts. And then trust in the messenger providing that information can be different. So there is some evidence that there are some areas of the world where trust is in modern medicine can be undermined by a legacy of misbehaviors in the past, and that's difficult to change. But I think still that's overall is kind of like second order. So even in contexts where there is a legacy of really horrendous behavior, and as a result mistrust, it's not the main reason why people are not in good health. And you can actually remedy that, through proper information and messaging. But up to this day, people sometimes do things that don't. For example, there's a nice paper by folks that show that when the U.S. Was tracking down Osama bin Laden, they were pretending to be doing a polio vaccine? No, they were doing a vaccination campaign, right? So they would go into neighborhoods, saying, okay, we're doing vaccination. They were so that they could enter houses, and then people realized, okay, this was not true. They were just trying to find Osama bin Laden. So that undermines very much trust in the system, because okay, if anybody can just show up at my door and pretend to be a health worker when they are not, the next time someone shows up saying, hey, I'm here to give you a vaccine shot for COVID, and you're like, no, thank you, and that's very reasonable. So you have to, if you see a context where mistrust is an issue or beliefs are an issue, you want to try to go back to the roots of that. So I'm a big proponent of the idea that culture is very much endogenous, and there is no culture of poverty, if you will. People don't voluntarily choose a culture of poverty or ill health.
I'm going to cut you off because I think we should end, because people have lots to get to today, this week. But thank you so much, Pascaline, and thank you, everyone. Another round of applause.